We're going to start in about 5 minutes. Participants are muted when they join the call, so you don't have to worry about pressing any controls. We have about 2 minutes until we're going to start. Just a reminder, when you do sign on, you will automatically be put on mute, so you don't have to worry about controls or anything. Yeah, we're going to get started. It's 1 o'clock. If other people can join as we get started. I want to welcome everyone. On behalf of IPRO and the Connecticut DPH, we thank you for attending this webinar and for your commitment to infection control at each of your facilities. So this is the first of 8 webinars we'll be hosting for this project period 3, and I thank you for attending. During the webinar, we'll go into depth about the ICAR tool, which is really what this project period is focused on, and we'll also highlight some of the project period 3 activities and expectations. As we have recently kicked off project period 3, we really want to make sure each of the facilities understands what to expect and what is expected of them. A housekeeping item regarding this webinar and all future webinars a part of this project, we are applying for CNEs. This one has been approved for 1 continuing education credit. So you will receive your certificates at the completion when you attend the full session and complete the survey that will be posted at the end. So make sure you stay until the end and answer that survey, and then you will receive your certificate via email. So this is the mission statement, which really aligns well with what we're doing in this project period, where IPRO provides a full spectrum of healthcare assessment and improvement services that foster the efficient use of resources and enhance healthcare quality to achieve better patient outcomes. Some objectives of this presentation include outlining the expectations of the Connecticut IPRO Project Period 3 activities so the facilities have a better understanding of not what only is expected of them in the coming months, but also what they can expect from IPRO and our team during this project. We'll move into really the bulk of this presentation where we will focus on the ICAR tool. As Project Period 2 was a continuation of Project Period 1 that was called Train the Trainer. And we also used it to kind of set the stage for this project period 3, which is based fundamentally around the CDC ICAR tool. As we closed the previous project period and started this current project, we did notice a gap in the understanding of the ICAR tool, kind of what it was and what we were doing with it. So we really kind of wanted to lay foundation for this project by kind of explaining in depth what it is, how it was developed, and how to really appropriately use this tool. We'll provide a summary of the common gaps that have been identified using the ICAR tool and what we've kind of seen at visits in the previous period and in the visits that have started already in this project period. Okay, so just a little recap of what we did in the previous project period 2. We are in project period 3 now, and the previous project was an extension of the initial Train the Trainer program. Goal in period 2 was to continue to support the trainers at each facility in their trainer role. This includes 4 educational webinars, 14 site visits. 3 were follow-ups from period 1, and 11 of those visits were new visits, so to speak. We did have that full day educational plenary. All our activities in project period 2 were in anticipation of these project 3 activities. So a large component of that project was the development of the infection control and hemodialysis training curriculum. This was a modular-based training curriculum based off the CDC ICAR tool. It provided either to you at the plenary if you came to the plenary in July, or mailed to you shortly after in August. Project period 2 was concluded in July of 2016 with the full educational plenary at the 4 Point Sheridan in Meriden. To all those who actively participated in project period 2, we do want to thank you. We do understand the multiple responsibilities and the many hats you all do wear, so we do appreciate your efforts you make to improving infection control and improving patient outcomes and participating in the activities of these projects. So the current period where we are now, it did start at the conclusion of project period 2. It runs is running from August 1st, 2016 through March 31st of 2018. This is a longer project period, so we do have some time to kind of space out some of the activities. We'll show you the schedule further on, but we're trying to kind of time things. So the activities are overwhelming, but we kind of can keep our participants engaged, and then obviously continue to support you through this process. So in this period, we will continue to obviously support the nurse trainers, but we're going to really be shifting focus to the CDC ICAR tool through the ICAR assessments conducted both by you at the facility and by iPro at the site visits, as well as using the ICAR-based training curriculum. So period, we will be asking all licensed facilities in the state of Connecticut. We'll be visiting all of the licensed facilities in the state of Connecticut. And at the end of the project, we will be making follow-up visits to at least 10 of those facilities. I often kind of get asked, why our facility? Why do you want to audit us? Why do you want to come here? And the answer is really we're seeing all facilities and attempt to do those ICAR visits and help you identify any gaps to improve your practice on. The visits are really a means to help and support you and by gaps so you can mitigate those gaps. And the primary focus as a means of gap mitigation is going to be the utilization of the training curriculum that was provided to you previously. Sessions will be recommended to each facility at the conclusion of the site visit, so don't jump into the curriculum and think you have to complete the curriculum in its entirety. We really want the facilities to kind of focus on the sessions that are most relevant to them. So they really will be just based on the facility's need. So during this project, we will be hosting 8 educational webinars. This is the first of them, and then we will do another all-day in-person plenary. We're taking the plenary to fall of 2017. This will be after all the initial site visits, but prior to any of the follow-up visits. So the project is really all about your facilities and you as the trainers and the infection control personnel. All participants are expected to take an active role in this project. This includes attendance and participation at all project activities, the webinars, the facility site visits, the plenary, and other training activities such as training sessions from the curriculum. We also are asking the trainers to utilize that curriculum in the training of their staff based on the iPro recommendations following a site visit and provide feedback to iPro. We want to know if the curriculum is working, if the webinars are helpful, if you have any ideas, questions, or suggestions. So feel free to contact us at any time with concerns, questions, recommendations, any comments you have. We're here for you. We want to help and support you so we can work together to improve infection control statewide. All right, so as project period 3 is just over a year and a half long, there are a lot of activities and dates to be mindful of. Again, to kind of space everything out in a manner that hopefully is less overwhelming but keeps you engaged throughout the process. This is a list of the primary activities. We will provide all the slides to you at the end, so you will have all the dates that I'm providing to you now via email. So the completion of Module 1 was really the kickoff activity of Project Period 3. Thank you to all of those who really completed the training with their staffs and returned it to iPro. Module 1 was an introduction to infection control. It was really infection control basics, but it also was to kind of get staff involved in their infection control practices to get them to really reflect on their practices and be more mindful of how their practices were really affecting the facility and their patients. At the completion of Module 1, we did ask that you complete a survey and then submit the pre and post tests back to iPro, whether it be fax, mailed, or emailed again back to us. We still are kind of waiting on some facilities to get that back to us, so we'd really appreciate it if you get those back to us as soon as possible. As we continue to have more activities and we come out to your visit, we will be recommending more sessions from the curriculum, so that work is kind of going to add up quickly. So we do ask that those come back. And just as a clarifying point, we were receiving a lot of the assessment trackers, which is really just the scores from a session. We are hoping to see actual pre and post tests so we can kind of take a deep dive into the questions, how they're being answered, and whether or not those questions are really reflective of the material that is being presented within the module. So again, the activities will include the 8 webinars in the project series. They'll be held at 1 p.m. every second Tuesday bi-monthly. I do have that full schedule for you a few slides down. All Connecticut facilities will have that initial site visit. They have started in September of 2016, and the initial visits will run through August of 2017. I will be sending out a request for those 2017 visits within the next few weeks. So, if there's a date or days that work better for your facility, if you can get back to me sooner than later, I can lock those days in for you. They do fill up pretty quickly. I can't really go to more than 2 facilities in a week. So the earlier I know, the more likely I can accommodate the date that's most convenient for you and your facility. So then again, we'll follow those initial site visits with that full day plenary in fall of 2017, and we'll conclude the project with follow-up visits to at least 10 of those facilities, and as we continue with the webinar series. This is the full schedule of the webinars for your record. The November 8th one is obviously today, so that will be one of the 8th. Then we'll have the January 10th, 2017, March 14th, 2017, May 9th, 2017, and then following the same schedule, this is bi-monthly on, bi-monthly on the second Tuesday. The September 12th, 2017, this is the date that we have slated for the in-person plenary. That scheduled, but just be mindful of that date, that will be a full day and an in-person event rather than a call-in at 1 p.m. And we'll conclude the project with the final 3 webinar dates, November 14th, 2017, January 9th, 2018, and March 13th, 2018. We do have some preliminary topics that we're going to cover on some of these webinars, but if you do, if there's need at your facility or you have noticed that might be interesting to you or helpful for your staff, please reach out to us. We're happy to hear your suggestions and hopefully meet any of the needs you may have. So please don't hesitate to reach out to us. I know a lot of people do enjoy hearing from the state surveyors, so we're hoping to get them on board at some point to host one of these webinars. We're looking into topics such as patient engagement and education related to infection control, antimicrobial stewardship, infections other than BSIs, and hoping to find a way to make data meaningful to the facilities, as each of the facilities kind of use NHSN in a different capacity. For corporate reporting or facility reporting, we want data to be utilized, in a way that's meaningful, so you understand really what's happening at your facility versus what's happening, across the state, across the country. So I know people tend to not get excited over data information, but we're trying to find a way to make it interesting and useful for us, because obviously for you guys, because obviously it is important in infection control. So a side note before we dive into the site visit objectives, while this is a partnership with the DPH, we are partnered with the non-regulatory side of DPH, the AI program. So I know there has been a lot of concerns that I'm coming out in a means to report back to the state or to make citations, and that's not the case. We're really coming out to just evaluate and provide feedback. It's really a visit for means of learning, so we can hopefully improve practice. So, it's never enjoyable to have somebody kind of be watching your every step. I get it from working on the floor myself. I never enjoyed having someone observe, but we're not there to make citations, really just there to help. So if your hesitation making a site visit date is easier, I am going to, be citing you in any way. That's not the case. We have a lot of positive feedback from the facilities we've gone to so far that it was helpful, and they did actually enjoy and appreciate the visit. So hopefully seeing more of you soon. But during these site visits, the objectives are to review the facility's self-completed ICAR, which is to be completed prior to the IPRO visit, conduct a formal ICAR ourselves to see where it stands and related to the facility self-assessment, and to see some of those policies and procedures in practice. Also to complete audits and make other observations related to the ICAR questions and domains. Observe training and simulation. This isn't meaning that you have to plan a training session while I'm there. we just want to see the tools you're working with as a trainer. So sometimes it can be as simple as, there's a new staff member on the floor, and educate that staff member on patient engagement or vascular access or something. A lot of times I've had facilities just quickly run me through how this simulated if there was a hepatitis B patient, whether they weren't there that day or they don't currently have a patient on isolation. We just kind of want to see the tools you're using and a kind of your teaching training technique. So this is something, big that you need to plan for. It's just a lot of times there's been an opportunity. I'm on the floor, a teaching opportunity that, the trainer will jump in and educate someone, and that's sufficient to kind of meet these requirements. So I know that point looks a little daunting, but it's really, again, not a big, it's not a big like training session that I'm asking you to run during the visit. So then really we're going to be focusing on opportunities for improvements based on any of the gaps we do identify, and then make training recommendations based on any gaps we do identify. What to expect a day of a site visit. This obviously changes a little depending on the flow of your facility. Patient care obviously comes first, and I'm not trying to, get in the way, if things come up. A tentative schedule that we stick to these visits as I do arrive to the facility just prior to those first patients being put on. This is when I'll collect the audits that the facilities are asked to complete for my visit. I'll review them quickly before I jump onto the floor, and then I will go onto the floor with the staff to complete the audits and observations of any that takes place during that first shift. There's a lot of downtime between that first shift and the first turnover, so that's when I usually have an opportunity to sit down with you, most likely those of you that are on call, and review any of the P&P that I do have questions on. A lot of the corporate P&P I have seen, whether it's at another facility or through other means, but sometimes I have some questions that are facility specific, so this is when we'll kind of take a little time to sit down and review some of the things and walk around the facility a little bit, which is mostly kept to the patient wing areas and the treatment floor, which I spend most of my time. So if there isn't an opportunity during the first shift for any of that training or simulation, I might ask, to see a skill just time or something of that nature. And then during the first turnover, I really will try not to bug you with questions or anything and really finish up the audits and make observations. I know they're really busy time, so it's time for me to do those audits as well, and I don't want to pull anybody away from patient care. And when this is all done, I do want to sit down for an exit interview or debriefing of my findings with nurse trainer, clinical manager, facility administrator, and medical director. It is important that all parties be involved in this process. We really want to kind of engage everyone and have all administration understand, what's going on at the facility with this project and what we're doing to support the facilities and hopefully improve on their infection control practices. These are some of the challenges that we've come across so far as we've started to roll out these site visits in this project. So I did highlight them so you can, what is expected of you. It is outlined in a letter we send when we set those visits, but to highlight some of the things that aren't always completed. So we do ask that the facilities complete their own ICAR prior to the visit and submit it back to IPRO approximately a week prior. Again, I will give you hard set time frames, but it's usually about a week prior. This is so I can review the document prior to the site visit. I have seen a lot of the incomplete CDC. I do ask that a bunch of CDC audits are completed prior to the visit. These don't need to be submitted back to me when they show up, but they do need to be available at the time of visit. I typically ask that those are completed within the 3 days leading up to the visit so that all the audits kind of show one snapshot in time. So the audits that are completed by you within those 3 days and then me the day of the visits are really in that 1 week period. We've had some lack of participation in the interview, the exit interview. This is where we want all administration available. So the nurse trainer, the clinical coordinator, nurse manager, the facility administrator, and the medical director. We do understand the challenges that not all of these members are present in each of the facilities at all times, but we do ask that you make your best effort to have them available. Worst case, if somebody does need to call in, that's okay, but again, if we could have everybody in person, that would be ideal. So now we're going to dive into really the bulk of the presentation in terms of what ICAR is and really what this project is all about. I know you've heard me say over and over again, the ICAR tool, the curriculum is based off ICAR, and I know some people are still on the fence of what it really is. So hopefully we can kind of explain this a little better to you. So we're going to kind of go over its development and its use. We'll do the Connecticut DPH program, the epidemiology and laboratory capacity funding, which is then related to the infection control and assessment response program, which is responsible for the development of this ICAR tool. So this is kind of a big picture of what's going on, and we'll relate back to what this project is and how we're really utilizing that tool. Like I said, the iPro and Connecticut DPH partnership is through the State of Connecticut Department of Public Health Healthcare Associated Infections Program. It's kind of a background on the program and our partnership. In 2006, a law was passed that mandated the reporting of healthcare associated infections. The CDC's National Healthcare Safety Network, or NHSN, as you guys are familiar with, was chosen as the surveillance and reporting system used to meet these requirements. And then the HA Advisory Committee was established as a result of the reporting regulations. So the program is under the Infectious Diseases Department of the DPH, whereas regulations fall into the Healthcare Quality and Safety. I just say this again to kind of lay our role as non-regulatory because we are working with the HAI program. So the role of the HAI program is to oversight of public reporting of HAI infection rates, provide information on infection risks and best prevention practices in healthcare settings, provide infection prevention education, provide consultation and assistance to hospitals and local public health for infection outbreaks, partner with professional associations, patient advocacy groups, and the public to inform, improve, and advance the sciences of infection control, healthcare epidemiology, and patient safety. That's where the iPro and Connecticut DPH partnership lies. It's a collaboration to improve infection control and patient safety outpatient hemodialysis facilities. That is what we are doing in this project. So the tool was actually developed as a result of the Ebola outbreak. I know most of you haven't really heard me talk about Ebola, but this is how our project was. I will kind of explain how the Ebola outbreak resulted in the ICAR tool and the project we're working on now. So in March of 2014, West Africa did begin experiencing the largest Ebola outbreak on record. And then in October of 2014 was when the U.S. public health system was really challenged with that first of the 3 domestic cases of Ebola. I'm sure most of you remember the case in Texas, which kind of sparked this scare and this outbreak in the United States. So the Ebola outbreak response really highlighted the vulnerabilities and infection control practices within the U.S. healthcare system. And as a result, the CDC response efforts provide an opportunity to identify gaps in the nation's capacity to deal with Ebola or other emerging or re-emerging infectious diseases. So as much as the public scare, and we're all familiar with some of those cases that happened domestically, a lot more came from the Ebola outbreak. The CDC and the U.S. healthcare system really learned that as a nation we weren't really prepared to deal with an outbreak, and that there really were a lot of gaps in the nation's infection control infrastructure. So the outbreak was essentially eye-opening and presented the nation with an opportunity to improve our practices and protect our patients in our nation. So I'm going to tie this slide back to the Connecticut DPH, iPro, and the ICAR, but to understand the whole picture, we need to understand the function of the ELC. This is the CDC's epidemiology and laboratory capacity for infectious diseases, the ELC. So this is to protect public health and safety of the country by enhancing the capacity of public health agencies to effectively detect, respond, prevent, and control known and emerging, re-emerging infectious diseases. So on May 1st, 2015, CDC issued funding to the state health departments through the ELC domestic Ebola supplement. This would provide support to states to address some of the gaps identified by the Ebola outbreak that occurred in 2014. Funding through the supplement supports efforts to define and apply basic standards of infection control in a variety of healthcare settings to strengthen policy and capacity at local and state levels to promote good infection control, and to actively assess and intervene to achieve best practices across all healthcare facilities. Three essential core elements that exist from the funding, which are really intended to prevent the transmission of infections in the healthcare settings. So the state health departments are to perform target assessments of general infection control competency in quarantines at healthcare facilities, gaps in infection control performance, and facilitate and implement programs and policy change to address gaps in staff performance, competency, and plan policy, and then to implement response and prevention activities aimed at making a large impact on reducing the transmission of pathogens on the population overall, so the reduction of HAIs. Through the domestic Ebola supplement provided funding for the infection control assessment and response program. This is the ICAR program. This is the program that's responsible for the development of the infection control assessment tools, the ICAR tool that we've been working with. The ICAR tool is for the health departments to assess infection prevention practice and guide quality improvement activities based on those ICAR findings. The ICAR tool is not just for dialysis. There is a tool also for acute care, long-term care, and outpatient settings. Currently, the state health department has already conducted ICAR visits to all acute care facilities in the state, and they are just starting to kick off their ICAR visits to the long-term care. And then obviously, we, IPRO, are responsible for the dialysis ICAR assessments as part of this project. Through the CDC's ESC, the Connecticut Department of Public Health did award IPRO the grant to conduct infection prevention strategies at patient hemodialysis centers, and this is our partnership, the partnership between the state and IPRO. The purpose of this partnership and this project specifically is to improve infection control through on-site assessments, identifying gaps using the ICAR, create a mitigation plan based on CDC resources, and follow-up assistance to support sustainability of infection prevention practices. So that is really what we're doing through March of 2018. So there's two different tools you'll find online when you're looking up the ICAR program, the checklist and the actual ICAR. The checklist aligns well with the ICAR. It really reflects all the everything covered in that ICAR tool. It's technically intended for use by, as a resource for facilities, but the facilities do have access to that ICAR tool, and that can be a valuable resource as well, as they really do touch upon the same things. The ICAR tool is what we're really using at the IPRO visits and the health department at their ICAR assessments through the other healthcare facilities across the state. Both, again, can be used as resources for the facilities. You know, we do ask you complete the tool prior to us coming. It's kind of to see where your infection control practices are prior to us coming out. So it's used even when you have a scheduled visit. It's not part of this project. It's a good tool to see what's going on at your facility. The purpose of these tools are really to identify the gaps, address the gaps, and guide quality improvement activities. So using the ICAR, and really the best way to use the ICAR is not just as a checklist. You know, yes, they are yes and no questions, but it really effective. You kind of need to consider the implementation of your PMP, your policies and procedures. Like PMP or lack of it affects your facility and your practice. And also to be mindful of that PMP not your practice, but if you're not practicing according to your PMP, that does result in state citations. So I'm not making citations. I'm not calling the surveyor, but you know, if we do see that you're not practicing according to your PMP, I let you know, and kind of make you more aware that that's something you need to probably mitigate sooner than later for your facility benefit. You know, a day if your PMP says one thing, but you're practicing another, that can result in a citation if it were to be a state surveyor situation. So you can use the ICAR as an observation tool. Again, even though it's yes and no, the audits are included as part of this ICAR tool, and a lot of the questions can be used to see what is going on at the facility. So, walk to the floor, tour the facility, and kind of evaluate the infrastructures and the practices that are occurring. And, of course, utilize those audits. The audits are a great resource for recognizing gaps in practice as well as gaps in the ICAR domains. The audits really go hand in hand with their related domains. Some of the common errors I've found in self-assessment that I've encountered so far through the site visits. They're often these are the questions that are answered incorrectly due to wording or misunderstanding of the question rather than gaps in practice. It's important to understand what the question is really asking to be able to answer it appropriately. So I did just want to review these with you. The common errors in self-assessment includes questions in domains 1, 5, 7, and 10. Domain 1, infection control policies and infrastructure. Question 3, has facility participated in the CDC DPH prevention collaborative? Most facilities are checking yes, and most facilities should be checking no. The Dialysis BSI Prevention Collaborative, this is a CDC initiative. It's a collaboration among outpatient hemodialysis facilities across the country. It is included in the ICAR as there's been a lot of valuable research and best practice coming from the work being done through the collaborative. And as the collaborative expands into what they're now referring to as the coalition, it's going to be a great resource for your facility, something you will be encouraged to participate in and use as a resource. However, for now, unless you really are working directly with the CDC in the collaborative, this really is no as an answer. Many facilities are answering yes because they use the CDC resources, utilize the tools, but this is specific to the collaborative work with the CDC and other facilities. So that's domain 1, question 10. Does the facility have an isolation room that is available for isolation of conditions other than hepatitis B? Most facilities are checking yes. What this question is really asking is, most facilities do have that isolation room for hepatitis B, but do you have a second isolation room that is being used for MDROs, whether it's C. diff, VRE, MRSA, and those other MDROs? Want to see that those patients are being isolated. So most facilities in Connecticut just have that one hepatitis B room that is for hepatitis B patients only. So this is just no issue, no answer, but that is what the question is asking. So then domain 5, respiratory hygiene and cough etiquette. This isn't specific to the question. This is this particular domain has 2 areas, and it's looking at non-clinical areas versus clinical areas. The clinical areas are typically referring to the patient waiting area. It is specified in the question, but some of the facilities are answering the questions in the non-clinical area section where the clinical areas, and your answers can really vary greatly depending on where you are, as you all know. So just mindful of that when you're answering that, where you are in the question and where you are in the facility. 6, personal protective equipment, PPE, which is question 4. Does the facility have a policy or a protocol for staff to routinely change their gowns in absence of soilage? So this really I wish in the tool that in the absence of soilage was highlighted. Most facilities are answering yes and writing when visibly soiled. This question is really looking to see that facilities have a policy in place for staff to change those gowns in the absence of soilage. Of course, you're changing, or you should be changing those gowns when they're visibly soiled or contaminated. But even when they're not visibly soiled or contaminated, those gowns are being used in dirty areas of the facility, are being contaminated in some fashion. So this is looking that the facility is changing them at regular intervals, and those gowns aren't being worn for an extended period of time. So I know most facilities do change them at the end of each day. So that, that's good, but this is what it's looking for. We're not just looking for it when there's soilage. So that's how to answer that question. Domain 7, environmental cleaning. Question 5, does it have a policy procedure for routinely emptying and cleaning reusable waste containers? This is causing some confusion among facilities. They're really looking for those, what you're doing with those biohazard containers, not the sharps containers, but the reusable biohazard containers. And I know a lot of the facilities contract out for this and, report emptying the bins what's full at the end of the day, and then a contractor does come in to change out bins for new clean bins a couple times a week. So it's really looking for what you're doing with those biohazard bins. Those are dirty bins, and if they're not regularly being changed and emptied, there is obviously a cause for concern. So that's how we might be looking at that particular question. All right, so domain 10, catheter and other vascular access care. Question 6. This is being answered incorrectly at almost every facility, and it's really, again, not practice. This is kind of confusing how the question is wording. But none of the facilities are using needle access anymore. Catheters are accessed with those needleless connector devices. So for the first part of question 6, does the facility routinely scrub catheter hubs with appropriate antiseptic after the caps are removed and before accessing the catheter? While this specifically does not say in relation to needle access, it is asking about needle access. So for all the facilities I've been to and all that I'm aware of, because your needle list, you would check not applicable and go to 6A. And then this is, if you're using those needle-less devices, you have does the facility routinely scrub the catheter hubs when the needle-less connectors are removed? So this is really, yes, there is some policy or procedure to, scrub the hub for those connecting devices. But, I mean, it could be no. That is how you would answer it. So nay, and then yes or no, depending on what's happening at the facility level. And the really common errors in the self-assessment, not really practice. So it's really due to the wording. So just reread the questions. If you do have any questions or concerns or don't understand the question, you can reach out to myself or Genevana. Those are our email addresses if you do have any questions. All right, we are going to jump into the common errors in practice. This is more important in terms of infection control. That yes, we want you answering the tool correctly, but more importantly, we're hoping, identifying too many gaps in practice. So this is where we can identify room for improvement to hopefully improve your infection control practice. So the ones I've found commonly through the site visits I've been to so far. This is just a quick snapshot of the questions with the most practice gaps. I will go into detail of each of them. So, and again, infection control policies and infrastructure. Question 5. Does the facility have a system for early detection and management of potentially infectious persons at initial points of patient encounter? While facilities are checking yes, and either the system applies at check-in or when the patient enters the treatment area, in practice, I have not seen this occurring at all. I in place at one facility that when the patient was entering the treatment floor, they were screened in the manner they were asked how they were feeling, but to see if they potentially had any respiratory signs or symptoms. And that really wasn't consistent. I only saw it with a couple other patients throughout the day, but that was really the only time I saw any system in place. Really, these patients should be identified as soon as they enter the facility. The earlier we can identify any potentially infectious person, we can separate them from the general population, provide them with face masks, encourage hand hygiene, and all of our normal infection measures. But this isn't really being seen anywhere, so it's something to consider implementing at the earliest point possible. I know a lot of the facilities don't necessarily have somebody in that waiting area or at the desk available, but the sooner the better. In domain 1 for common errors in practice, we're going to jump to question. This is the distance between adjacent dialysis treatment stations. Now, many facilities do have that shared computer terminal, so your automatic answer is less than 3 feet because there is equipment. There is no separation between stations. Recommendation is 6 feet of separation, what symptomatic or not. That is what is recommended to decrease any kind of cross-contamination. Now, this obviously isn't necessarily feasible. There's a certain number of chairs and there's only as much space, but it is something to actually be mindful of during flu season. So while this is a general rule, whether they're symptomatic or not, understand there really are just limitations of the facility. If you do see a symptomatization, a lot of the facilities do have some capability at some of those end stations to separate those patients farther from the general population. So just be mindful of that, especially as we're really kind of coming into flu season here. So 5, respiratory hygiene and cough etiquette. Question 3, does the facility provide space and encourage persons with symptoms respiratory infection to sit as far away from others as possible? So then to the previous question, it really occur in both the waiting areas and on the treatment floor. Again, an individual should be identified early as discussed in Domain 1, Question 5, so they can be separated starting in the waiting room. And other precautions can be rolled out as we already discussed, such as the mask, hand hygiene, etc. So question 5, does the facility offer face masks upon facility entry to patients with symptoms of respiratory infection? This, again, still ties in, but this is really a big one. I've seen face masks only offered at one facility, and it was to a patient who had already come through the area, had entered the treatment area. They were already treatment then initiated, and they have been identified, but from the moment they entered that treatment floor, they were coughing. They had a very mucus productive cough, and I happened to be auditing the staff member who was cannulating that patient, and I stepped back pretty far from the situation because they were clearly very probably, infectious. And the staff member did look at me, and we kind of, made eye contact, and I gave that kind of suggestive eyeball, like something needed to be done. And they were offered a mask. Whether it would have been offered if I was there, I'm not sure. But that patient had been, exposed to, other patients and staff had been exposed to that patient, and this was kind of a late intervention. But this is something earlier the better. And not to mention that patient was happy to do it. He actually made some comment like, oh, I don't want to get you guys sick, speaking about the staff members and other patients. So most of the time, I know we all, there's patients that aren't we'll just call it curmudgeons, that might want to necessarily do some of these things, but a lot of times they're more than happy. They don't, they're in a community with their other patients, and they don't want to get other people sick. So then 6, personal protective equipment, PPE. Question 3, substances necessary for adherence to PPE recommendations are available and located near point of use. And then it goes through all the PPE. One thing I've noticed consistently through the site visits is lack of gloves. There might be multiple boxes, but a lot of times they're all in extra large, they're all in small. There aren't the gloves in the appropriate sizes for the staff to use. One particular facility had just small and extra large, so there was no medium and large. And I know most of our staff do use medium and large gloves, so they were either had an extremely baggy glove or couldn't put their hand into the glove to provide care. So, and you need to be using the PPE correctly, but in order to do so, you need to have proper PPE available. Some things to also consider regarding PPE use is many times I see a gap between the gloves and the gowns exposing skin for staff members, so possible risk there. And the masks below the nose, especially during catheter care, you really need to make your nose and the patient nose is covered. And then the improper use of gowns, whether they're end up all the way enclosed or exposed. I've seen hoodies over the back of gowns, or not in the gowns at all when going to a patient station. So those are some things to be mindful in regards to PPE. Right, we're going to skip to domain 7, environmental cleaning. Question 6, does the facility have policies and procedures to ensure reusable medical devices, thermometers, stethoscopes, pressure cuffs are cleaned appropriately between patients? So the blood pressure cuffs are often machine specific and but they're not being thoroughly cleaned, if at all. This should really be a part of the station routine disinfection. And this, the cuffs are on the patient. They're in contact with the patient. I've seen those really not down well at all. So this is, something to really highlight when you're really doing that disinfection. Also, a big concern is the use of the stethoscopes. While some are machine specific and then would have the same protocol in terms of being cleaned during the routine state disinfection, are oftentimes the stethoscopes that are left at the machines and nurses are carrying around their necks from patient to patient. Technically, anything that goes into a patient station should not come out. Needs to be clean when it comes out, whether it is the glucometer, the thermometer, or the stethoscope. And I'll see that being worn on a neck, the stethoscope being worn by a neck from station to station to station, and that it needs to be cleaned every time you leave. So obviously, I wouldn't wear it around your neck, and it needs to be then put into a clean area. And sometimes when there is a communal stethoscope, I've seen that stethoscope not being cleaned between patients. It's sometimes the bell's wiped down, but I've seen a lot of reuse of that stethoscopes without any disinfection in between, so that is obviously concerning. In the same domain, the audits related to that domain, this is probably where I've identified the most gaps and really is the biggest room for improvement. Pretty much every single facility I've seen so far. I know we're getting close on time, so I'm going to try to speed up a little bit here, but I do definitely, this is an audit that you need to be dealing about and really go over your staff the proper way for disinfection. So part of taking down the dirty supplies from the patient includes emptying that bucket. A lot of times that's still left at the machine and is emptied later in the disinfection process, but as it is considered dirty, it needs to be removed when any disinfection is initiated. Also, station needs to be empty before any disinfection is initiated. This includes the asterisks on the audits. If you look down at the bottom, do specifically refer to this includes patient. Most facilities are not, still waiting for that patient to leave, and I do understand the time constraints, but it is considered, risk for cross-contamination by having that patient still there. I have seen some facilities implement really waiting for the patient to leave the station before any disinfection has been initiated. And while they've, reported to me while the change was taking place, it did in fact take more time after it became part of their practice. They didn't really see an increase in time. So, I know most facilities aren't practicing that way right now, but there is a push for it really to, to reduce cross-contamination by having that be a part of practice. So just to keep in mind as you're making changes to your infection control practice. Across the board here, disinfecting all surfaces. This does include the prime bucket. Again, this isn't often wiped out. You get the backs of the machines. You kind of need to get all those nooks and crannies. So you need to cover really as much of that machine as you really can. A chair, inside arms of the chair, the tray tables, everything. There's a lot of contamination, or so that needs to be part of it. The other thing is it really needs to be visible. Those bleach cloths dry out very quickly, and after a couple wipes, you're not really covering surfaces. You're not making them really wet with disinfecting, so they really should be visibly wet, not dripping wet, but where you can see that wet residue, and then left to dry before any other equipment is brought to the station. So this, again, the supply should be brought back to the station until disinfection is complete. Includes, obviously, if the patient's still there, which often happens, or if that chair hasn't been cleaned, that machine shouldn't be set up yet. I'm going to get ahead here. So in domain 9, I didn't see any common gaps in the actual domain, but the audits related to that domain with the hand hygiene. This obviously, there's always gaps in hand hygiene. No one's perfect, but some of the common gaps in the interest of time is often with the gloving, whether it's before or after gloving. inadvertent touching of like your hair, your face, the patient, without changing your gloves and performing hygiene, no hand hygiene before cleaning computers. And oftentimes I've seen staff that weren't the nurses or the techs, but the MDs, dietitians, and social workers who aren't as frequently on the floor, being the culprits of not performing hand hygiene and going from station to station. So domain 10, catheter and other vascular access. The CDC is really pushing for the use of antimicrobial ointment or chlorhexidine embedded dressings on the catheter exit site. It has been showing to reduce BSIs, and not a lot of facilities are doing it, but there is a big push from the CDC for this to become a part of practice as part of the collaborative, and some of the recommendations are here. But it is in the resources at the end, too. So if you want more information on that, this isn't being used at many facilities. As I'm going so quick, but I don't want to hold you guys over. So in domain 10, domain 10, the audits, the catheter, this does include catheter exit site care, catheter connection and disconnection, and cannulation. Some of that I'm finding is the mask being improperly worn. This is often below the nose, whether it's the patient or the staff. The catheter hub during connection or disconnection is not being scrubbed for a sufficient amount of time. In the exit site care, this also includes the skin antiseptic not being applied appropriately. The recommendation for the chlorhexidine, which is typically used at the dressing site, is a 30-second scrub and a 30-second dry. I don't even see clocks available for to look at and really time themselves while they're doing it. And sure, you can count, but we all know 30 seconds in patient it feels like minutes. So to have those clocks visible would be helpful in meeting some of these recommendations, as their watch should really not be showing. Those gloves and gowns should be completely covering their skin and clothing, so they shouldn't be using a watch. They should be using a wall-mounted clock. And all the antiseptic, whether it's the hub or the exit site, needs to be allowed to dry. And then again, the antimicrobial ointment on exit site care is recommended. To note, this because your facility is not using the antimicrobial ointment or chlorhexidine embedded dressing, this would not be a check in that box. So if that's not part of your practice, that would typically result in 0 audits out of the 5, 10, however many are performed. Emulation, the biggest gap is that site being cleansed with soap and water, whether it's the patient entering, obviously is most ideal, but if they aren't, it is okay for staff to use water, paper towel, and then dry it, or those paws that I've started to see more and more in the cannulation packets, which is efficient, but it needs to be done one way or another. Again, the skin antiseptic applied and dried appropriately. If you ever have questions on the scrub and dry time, it should be on the manufacturer's recommendations on the manufacturer's packaging. And then just to be careful that the cannulation is performed aseptically. All times between the arterial and the venous cannulation, the staff member touches the patient, touches something else, and then continues to perform cannulation. So just be mindful if you do touch something else that then needs to be, a change of gloves and hand hygiene. So domain 11, injection safety. Question 4, does the facility have a policy and procedure for routinely cleaning surfaces where injectable medications are prepared? All facilities don't have P&P, and the ones that do have P&P are not following it. This has been an issue at most facilities, so just consider you don't have the P&P that you really should be cleaning that site at regular intervals, and obviously PRN if it ever is visibly dirty or there's a spill of any sort, and just to keep supplies nearby for easy access. Those audits tools, I've seen a lot of audits just kind of checked across the box. It's pretty evident who's really doing the audits as they're intended. To mark a check mark across the box is not to count against you. It's really a learning opportunity. These are great tools to really evaluate your practice and identify any gaps that are existing in your practice. Facilities that aren't using antimicrobial or they're practice isn't to really have those patients leave the stations that are giving themselves 100% of the audits, aren't accurately using those audit tools. So there's some things that are not happening regularly in practice that I see on the floor, but they're being marked as a success in the audit tool. And I think that the approach to audits, if it's used as a learning tool and it's not like a ding against you, it can be a great tool to really highlight those gaps to then make improvements. The facilities have told me they've had good luck by including other staff members in the auditing process. It makes them kind of mindful of their own practice by identifying gaps in others' practice and realizing that the process isn't about pointing fingers. It's really a learning experience where we can all kind of improve and learn from. What's next in this project and really following that ICAR assessment after it's completed by the facility and then completed by during your site visit? We'll sit down, have that exit interview to kind of go over the things that we immediately spotted, but then we will pull together a more formal report that outlines kind of everything that identified, and we'll submit the report and a letter with training recommendations. We ask that that letter be signed by the trainer, the clinical coordinator, manager, the facility administrator, and the medical director, and be submitted back to IPRO within 2 weeks, just so that this was, seen and by all members of the administration. And then within that letter, we will be recommending training sessions based on the visit findings. We're recommending 1 to 3 sessions depending on kind of what we saw at the visit. We are trying to, identify the biggest need and not recommend more than 3, as we want the focus to be on the things that are going to make the biggest difference. And then for each of those sessions that's recommended, you're given 6 weeks to complete each session. All these time frames when we submit that will be mapped out to you. But again, if you have any questions, you of course can reach out to us here at IPRO and we'll help you through the process. And then obviously continue to attend webinars and the plenary. So some final conclusions. Infection prevention is the ultimate goal. We're going to be using the ICAR in the curriculum, and we can identify and mitigate gaps in infection control. So I know we're pretty at an hour. If you do have questions, you can submit them to the chat, or you can email me, and we can get back to you as soon as possible. So just make sure to complete that survey so we can submit the CNEs. I apologize for rushing at the end here. I wanted to make sure to fit everything in. But thank you again for coming and for your participation in this project and for your commitment to your patients and to improving your infection control practices.